Hi, it's the 21st of October 2016, and this is the RheumNow Week in Review. I'm Dr. Jack Cush, Executive Editor of RheumNow.com, coming to you this week from my office on Thursday evening. We're going to review this week's highlights from the website and from the social media feeds, and start with a study called the Surprise Study. This is a Japanese study that looked at patients with rheumatoid arthritis who were incomplete responders to methotrexate, and then were randomized then to receive either continued methotrexate with tocilizumab or tocilizumab monotherapy. 223 patients enrolled in this 2-year study, but primary endpoints were 24 weeks and 52 weeks, and they showed that it was the combination group that actually had the better responses and at better x-ray responses at 24 weeks. The patients who were taking methotrexate and tocilizumab compared to just the monotherapy. In the end, after a year or more, both groups seemed to have done about the same clinically, with remission rates and DAS scores and whatnot looking the same, but the greater degree of x-ray protection was seen earlier on, along with higher DAS28 responses in the first 24 weeks on the combination group, sort of supporting the general concept that 2 drugs is better than 1. Rheumatoid arthritis is a highly complex disease. Another report actually looking at just psoriasis patients and what happens to a large cohort of patients with psoriasis after they fail a TNF inhibitor. When they looked at those patients and looked at whether they were primary or secondary non-responders to their first TNF inhibitor, not surprisingly, those who were primary failures, meaning they never responded to the first TNF inhibitors, were less likely to respond to a second TNF inhibitor. This data actually has been seen in other trials in rheumatoid arthritis and other arthritis patients taking TNF inhibitors. So the same findings seen now just in a psoriasis-only population. An interesting study looked at the prevalence of ankylosing spondylitis in the United Kingdom, those in general practice versus those in rheumatology practices. And their impressions were, based on the data they found, was that 1/3 of patients were under the care of a rheumatologist. I would have guesstimated that that's somewhat high, but nonetheless, there's obviously a large gap in the delivery of care to patients with spondyloarthritis, and this supports some of the data that Atul Deodar has been out there talking about, which is, although the spondyloarthropathies are as prevalent as are patients with rheumatoid arthritis, they are not as likely to be seen in a rheumatology practice. So you probably need to work harder to get these patients into the clinic. 2 interesting studies sort of published back to back looked at a total of 169 patients and the yield of ultrasound-guided synovial biopsies. Many rheumatologists are doing ultrasound. Some could actually do synovial biopsies, and this may be an important research tool, rarely an important clinical tool, but nonetheless, they did show very high success rates in achieving histologically acceptable samples of synovial tissue with a very, very low complication rate. So somewhere between 82 and 93% of these patients who were biopsied gave a good diagnostic yield, suggesting utility of this particular measure. Another study looked at 104 patients with ankylosing spondylitis and spondyloarthritis and looked at the reliability, if you will, of SI X-rays, especially in patients with early spondyloarthritis. So this particular study was an early spondyloarthritis study, and it did show, unfortunately, that even with very experienced radiologists, that the variability in interpretation was unacceptable, and that the correlation coefficients were, although significant, it was not clinically meaningful, and suggested that early on, reliability of X-rays in diagnosing sacroiliitis may not be as great as we would like it to be. I don't know that I would use this data to rush out and start doing MRI on everyone. It means that we need a little more research in this area. I had a patient this week who has severe ankylosing spondylitis with near complete fusion, including that of his partial fusion of his cervical spine. This patient complained of significant balance issues that was related to his fused spine and his posture. In all the years of managing spondylitis patients, balance has never often come up, so I looked this up. Turns out that actually postural abnormalities do lead to significant problems, not only with spinal metrics, but also balance in a study that looked at a number of objective measures of balance in patients with ankylosing spondylitis. So that's certainly a significant problem, because a fall in a patient with a fused spine and ankylosing spondylitis could result in a life-threatening fracture to the vertebral column. So this needs to be something that should be addressed by physicians. It needs to work with physical therapists to prevent falls and to try to look into other potential causes of balance issues in our patients. Another study looked at sleep apnea and patients undergoing surgery. It showed that patients who were pre-surgical, who were found to have sleep apnea, were at a statistically higher risk of developing both atrial fibrillation and venous thromboembolic events, something the surgeons and those of you who do pre-op on our patients should know about. An interesting report sort of revealed the information you probably would expect, but the use of pregabalin, also known as Lyrica, has been shown to, in a study, to significantly decrease the amount of abdominal pain associated with irritable bowel syndrome. Certainly, pregabalin is a useful tool in managing pain and managing many of the difficulties associated with fibromyalgia and related disorders. Not surprising that would be effective also in IBS. And lastly, from the social media feed, a small study, but important study, of 16 patients undergoing a renal transplant, that in spite of having end-stage renal disease and then having a renal transplant that was successful, they went on to continue to receive their TNF inhibitor therapy that was given for a myriad of reasons, including rheumatoid arthritis and IBD, etc. But that what they showed is that in these patients who had significant renal issues, there was no decline in GFR after 2 years of follow-up. But the one major problem in this cohort, while their kidneys did fine on a TNF inhibitor, this particular group, renal transplant, renal disease, TNF inhibitor, is at a higher risk of developing serious infectious events, such that half of these patients had SIEs in the course of their being followed up. A major study reported in the news this week, hasn't yet hit the rheumatology journals, or I don't think it's going to be presented at ACR, is the NOR switch study. It may be a late-breaking abstract. As you know, in Norway, they were one of the first countries to take on the biosimilar for infliximab, over there called Remsima. They received a 70% discount for the use of Remsima, but part of the deal was that they had to study the adoption, success, and transference to patients onto the biosimilar. That's called the NOR switch study. It was an important study. It just recently was presented at a GI meeting in Europe, where they showed no difference in efficacy, no difference in safety in the patients who were switched, and those switch patients were compared to those who continued on receiving the parent compound Remicade. So this is one of the important early trials, and a lot going on in the area of biosimilars. Inflectra, the first infliximab biosimilar to be approved in the United States, that was back in, I think, February or March, is due to be shipped by Pfizer in the second half of November this year. And hence it could be on the market as early as December. There currently are no patent litigation issues that may interfere with that, but that Janssen is trying its best to maintain the use of its product Remicade, and has stressed the fact that there are no standards and benchmarks for the interchangeability issue, meaning patients who were on Remicade, doing well on Remicade, should they be immediately changed to this cheaper form of infliximab? It's going to be known as infliximab DYYB as a suffix. It will be marketed as Inflectra, and in spite of the projections that biosimilars would be cheaper to the tune of 30% cheaper, they're not going to be anything like they got in Norway, 70% cheaper. It's only going to be 15% cheaper when it's marketed here in the United States. It's also unclear whether or not the Hospira, the division of Pfizer, will be providing the same amount of patient support, including copay support, going forward. So there's a lot to be learned with the new marketing of biosimilars, which could start even by the end of the year. There's a nice report about low molecular weight heparin not being effective in reducing pregnancy complications. As we know, low molecular weight heparin can be very useful in patients with the antiphospholipid syndrome and recurrent fetal loss. However, in other high-risk populations who don't have the phospholipid antibody present and that syndrome present, that the use of low molecular weight heparin did not protect against other complications. And lastly, there's a nice review on the website that was published this week from Cassie Calabrese, where she reviews the incidence and frequency of herpes zoster in our immunosuppressed and autoimmune patients, showing that it's higher, which is expected, but some of the things in that report were somewhat surprising, including the fact that zoster events were more frequent using non-TNF inhibitor biologics than the TNF inhibitor biologics. You might want to read that to get some more insight about zoster, something you commonly have to deal with in your population. So that's it for this week at RheumNow.com. This is the Week in Review. Go to the website to watch the video, to click on the links to read more about these particular reports. You can download the podcast by going to iTunes. Again, I would encourage everyone who hasn't already done so to register on the website. You'd be doing me a big favor. It allows you to have more access to the full strength of the website. That's it for this week. We'll see you next week. Have a great weekend.